Rheumatology and Rehabilitation, Sri Lanka. Today we have three eminent speakers. First one by Dr. Balasundaram Parthippan, Senior Registrar in Orthopaedic Surgery. Dr. Parthippan will be doing presentation on ankle and foot examination. And second presentation by Dr. Duminda Munidasa, consultant rheumatology and rehabilitation from Rehabilitation Hospital, Ragama. Will be doing amputee rehabilitation. And third one by Dr. Uthpala Dissanayake, consultant rheumatologist at Teaching Hospital, Kegalle. Will be doing overview of thrombotic microangiopathy. So may I invite Dr. Parthippan to present on ankle and foot examination. Over to you, Parthippan.
Thank you, ma'am. Hope everyone can see my screen.
Yes, we can, Parthippan.
Yeah. Okay, thank you, ma'am, for this opportunity to share my knowledge to these extended subspecialties. And thanks to this little chap who has changed our learning experiences, teaching learning experiences has been changed by this little chap. And now we are moving towards this virtual learning era. And today we are at the extreme of it. We are trying to learn ankle examination through virtual learning. So I will try my very best to make it more palatable and understandable, even though it's a bit a difficult task. And today my topic of discussion is supposed to be ankle and foot examination. But what I thought was, if we go to YouTube, if we go to the YouTube and search for the same topic, we will be getting enough videos. So I thought of changing the topic a little bit. As I'm talking to the future radiologist, I'm going to make it a bit more clinically oriented. So my topic will be foot and ankle pain, where and why. Where is it originating from and what are the possible causes? So I will be making it a bit more clinical. So we as orthopedic surgeon usually divide foot and ankle pain into these 5 common sides: heel pain, lateral sided pain, medial sided pain, anterior and forefoot pain. So this will be the basic route map for the diagnostic workup. So I will be classifying according to this, and starting with the heel pain. When we talk about heel pain, we usually divide it into 2 as infracalcaneal pain and retrocalcaneal pain. So first we will talk about the infracalcaneal pain. Main causes are plantar fasciitis, calcaneal stress fracture, and heel fat pad atrophy. So plantar fasciitis, of course, you all know better than us. So usually it's an inflammatory pain. So it's worse in the morning. It's worse on the first step, but it improves with walking. And they have the classical tenderness over this medial aspect. This will be the highest tender point. And when you passively extend the big toe, that will stretch the plantar fascia and that will worsen the pain. So these two will be diagnostic, and I will be talking about calcaneal stress fracture. But when you press on either side of the calcaneum, in plantar fasciitis, there won't be any tenderness. Whereas in calcaneal stress fracture, this squeeze test will cause severe pain. That is how we differentiate this between these two. And I want to highlight on this fact: if a patient comes with plantar fasciitis, which is resistant, always look for the degree of dorsiflexion that is possible. Because proven, a resistant plantar fasciitis has an associated Achilles tendon tightness, which has to be addressed. So look for the degree of plantar flexion, and if possible, perform the silver scale test where we assess the dorsiflexion in full extension of the knee, and then at 90-degree flexion of the knee where we relax the gastrocnemius. So look for the Achilles tightness, and it is proven that more than ultrasound therapy and steroid injection, Achilles stretching exercises have benefited in patients with Achilles tightness and resistant plantar fasciitis. So we will have to make this a habit. In resistant plantar fasciitis, we have to look for the degree of ankle dorsiflexion and assess for the Achilles tightness. So the other different, before I go into the other differential diagnosis, radiologically, if we go for a plantar fasciitis patient, if we go for an X-ray, we will see this heel spur. Yes, definitely this is associated with plantar fasciitis, but the problem is this can be completely physiological. So presence of this heel spur does not always indicate a pathology. So we have to keep that in mind because this can be sometimes misleading. Whereas we will be talking about this spur later, which is always pathological. So this can be completely physiological. The next differential diagnosis is calcaneal stress fracture. The pain is mechanical, so it's not at the first step, but it worsens with walking and is released with rest. It's in complete contrast to the plantar fasciitis. And as I have already said, if you press on all this either side of calcaneum, you will get this squeeze test positive, which will be negative in plantar fasciitis. Because this is very difficult to diagnose radiologically. Of course, if you have a clear line like this, yes, possibly we can detect this, but at the early stages, it will be just a shady line like this, which can be easily missed. So clinical diagnosis is always better. The last diagnosis, the differential diagnosis will be a heel fat pad atrophy. The difference is they are having fat pad atrophy on the weight bearing areas. So as they weight bear, they will get pain. So this pain is present at the very first step and it's throughout the walking time. And the tenderness will be all over the heel. There won't be any specific tender point all over the heel. So I'm just making a chart to show that if you go along the route map, it's very easy to come to the diagnosis. These are our differential diagnosis and the pain itself has a different. This is an early morning pain which improves with walking. That is plantar fasciitis. Whereas in calcaneal fracture, it's a mechanical pain. No pain at first step, but as they walk, it worsens. And fat pad atrophy is pain from the very first step and throughout their walking time. And the tenderness will be along the anteromedial aspect in plantar fasciitis, on either side of the calcaneum in calcaneal stress fracture, and all over the heel fat pad in fat pad atrophy. So it's easy if you follow the route map and go on a focused examination. Other topic will be the retrocalcaneal pain. I would like to introduce these three topics. These may be repetition and don't take it as an insult because I'm just covering up the topic. So there are three entities: Achilles tendinosis, Achilles paratendonitis, Achilles insertional tendinitis. In addition to that, there can be retrocalcaneal bursitis, Heglund deformity, and posterior impingement. So how these first three differ? What is Achilles tendinosis? It's a pure degenerative condition with micro tears and failed repair process. There will be micro nodules, which are fibrous nodules. These nodularity will worsen and lead to pain and swelling. And you can feel some tender nodules. And the plantar flexion power will be reduced. It will be reduced. It won't be absent. It's not like in ruptures. These will be reduced. And if they ask the patient to do a heel raise test, single heel raise test, patient might be able to perform. But if you have to repeatedly do it, there will be difficulties encountered by the patient. And here they talk about this classical sign, painful arc sign, to differentiate this from paratendonitis, because paratendonitis is the covering and inside that the Achilles tendon glides. So if there is a painful nodule on the Achilles tendon, it will move as we take the patient through the range of motion, dorsiflexion to plantar flexion. Whereas in paratendonitis, the tendon nodule will not move with movement of the ankle. So that helps us differentiate between Achilles tendinosis and paratendonitis. So that is known as the painful arc sign. You locate the tendon nodule and passively dorsiflex and plantar flex, and you will feel that the tendon nodule is moving. And also assess for the dorsiflexion and silver scale test in any patients with Achilles tendinosis. And remember, this is a pure degenerative condition and there is a problem with the biology. The blood supply is compromised in this area. But paratendonitis is and you can see the name, this is a tendinosis, which is a degenerative condition. It does not have anything to do with inflammation. Whereas paratendonitis is a pure inflammatory condition, which you get in athletes, at least in weekend warriors who on and off go take part in athletic activities. They will come with this typical sausage-like swelling over the Achilles with tenderness throughout the Achilles tendon. And there may be nodules present, but these nodules will not move as you plantar flex or dorsiflex the ankle. So the painful arc sign will be absent. So the management is different. These will nicely respond to NSAIDs. And there is always a place for ultrasound guided lignocaine injection deep to the paratenon to prevent adhesion formation. So we have to differentiate these two. Whereas insertional tendinitis is a completely different entity where there is perfect biology, there is enough blood supply from the calcaneal blood vessels, but mechanical factors are causing continuous irritation and inflammation. So they will present with this pump bump, which is not retrocalcaneal bursa. This is a very superficial subcutaneous bursa because of mechanical irritation, and they will have painful plantar flexion and difficulty in performing heel raise test. So why do we need to differentiate this from Achilles tendinosis? Achilles tendinosis is a degenerative condition. Here, some mechanical factor is causing the problem, which can be internal or external. What is external is malfitting shoe wear or anything that is causing mechanical irritation. Internal is the Heglund deformity, where there is an abnormal bony prominence that is impinging on the Achilles insertion site. So always look for etiology, mechanical etiology. So this is the Heglund deformity that I was talking about. So how do we define this Heglund deformity? Anything that is prominent doesn't mean that it's Heglund deformity. So that is defined by this Pavlov's line. You mark the inferior both tuberosities, anterior and posterior tuberosities, and connect it with a single line. And then identify the superior most point of the calcaneum and draw a parallel line to this line. A parallel line drawn at the superior tubercle, parallel to this, should not be bisecting through the calcaneus. If it traverses through the calcaneus, anything beyond that is a Heglund deformity. So this is how we radiologically define Heglund deformity. So in any resistant cases of retrocalcaneal bursitis or insertional tendinitis, always go for lateral X-ray and look for the Heglund deformity. So the final entity is the retrocalcaneal bursitis. So this is the retrocalcaneal bursa. As I said, what we see as pump bump is a subcutaneous bursa. This is retrocalcaneal bursa. If they have a retrocalcaneal bursitis, you will see fullness of these two gutters. It comes as an hourglass swelling. So there will be fullness of these two gutters. And if you press anterior to the Achilles tendon, that is 2 finger squeeze test, that will be tendon. So that is retrocalcaneal bursitis. Finally, posterior impingement, which is quite rare, but we have to always think this in differential diagnosis. There will be a posterolateral tenderness. There won't be any tenderness over the Achilles tendon. If you pass the Achilles tendon and poke your finger in, there will be tenderness. And if you go for extreme passive plantar flexion, that will cause impingement and cause pain. So this is about passive plantar flexion. Previously, we were talking about active plantar flexion. Here, the passive plantar flexion will cause pain, whereas in Achilles tendon, passive plantar flexion will not cause pain. So if it is passive causing pain, we always go for lateral X-ray to look for this small chunk, that is ostrigonum, which is known as ostrigonum syndrome. Moving on to the next route, that is lateral sided pain. The commonest one will be the Atfl injury, then followed by high ankle sprain, peroneal tendinitis, or Jones fracture. So what is this Atfl injury? If you have an inversion injury, the lateral structures can be stretched and there can be tear or strain. So that is Atfl injury. So as I have marked here, this is the fibula, and you see this is vertical structure is the calcaneofibula, and this is posterior talofibula, and this is the anterior talofibula, which is commonly injured. So they will present with classical tenderness at the antero-inferior part of the fibula with some swelling if it is an acute stage. But if it is a neglected case, there won't be significant tenderness. And there will be an inversion instability. How are we going to assess this inversion instability? As I have demonstrated here, I have kept this. If you are connected from home, you can try it on yourself. If you have your foot completely neutral position, that is dorsiflex, and try to invert, ATFL is relaxed. Once you dorsiflex, the ATFL becomes relaxed. So at this point, if you try to invert, the inversion is resisted by calcaneofibular ligament, which is very rarely ruptured. It's a very strong ligament. But as you plantar flex and invert, and invert. If the inversion is more compared to the other side, then you are dealing with a patient with ATFL laxity. And then anterior drawer test. Now you can see if I try to translate the foot in relation to the tibia, if I try to translate the foot anteriorly, the calcaneofibula or the posterior talar fibula will not be able to antagonize that movement. That is only possible by the ATFL, depending on the ligament course. So if I stabilize the tibia and if I hold the heel and try to anteriorly translate the heel, anterior drover test will be positive if there is an ATFL injury. The problem is we will be seeing patients with acute injury, which is easy to diagnose. That will be anterior tenderness and swelling, but you will be seeing patients with instability and it's difficult to diagnose. So we have to elicit these signs. And as I have mentioned here, if it is a delayed presentation, they come with medial sided pain. They don't complain of pain on the lateral side. That is because there is an instability of the ankle and there is increased inversion, which will cause medial impingement. So this can be misleading. So late presentation will be medial sided pain. When we have, if we try to elicit instability, there will be a lateral sided instability. The other entity is the high ankle sprain. That is the syntesmosis ligament, which connects the lower part of the tibia to the fibula, which can get damaged, and they will complain tenderness on the anterolateral aspect of the ankle. So this syntesmosis ligament is ruptured. So the tibia and fibula is trying to get separated. And if you try and squeeze and compress the fibula onto the tibia, they will get pain because you are squeezing around against the unstable joint. So this is known as the squeeze test. We are about 5 to 6 centimeters above. You squeeze fibula onto the tibia. Only thing that we should remember is fibula is not exactly lateral. It's posterolateral. So this hand should be with posterolateral. Otherwise, we will be squeezing both hands on the tibia. So it should be posterolateral, and if you squeeze, if they get tenderness exactly here, you are dealing with a patient with high ankle sprain. Or you can stress the unstable joint. Initially, we were compressing with the squeeze test. Here, we are stressing and trying to separate the fibula from tibia. So what we do is we dorsiflex and try to evert the foot. We dorsiflex and externally rotate the foot. This force will try to separate the fibula from tibia, and this will again cause severe pain here. So compression or distraction will both cause pain if the patient is having a high ankle sprain. These are rare entities, peroneal tendinitis, where you will have a tenderness posterior to the malleolus, lateral malleolus. So initially ATFL and injuries will be anterior. Here is a posterior tenderness. And as you all know, peroneal tendon is an everter of the foot. So if you try to resisted eversion, patient will complain of pain or inability. So that is peroneal tendinitis, and the very rare entity is a Jones fracture, which if neglected will go into definite non-union. So these are Jones fractures. If metatarsal base, the problem is peroneal brevis tendon is attached to this part and there will be a continuous pull by the peroneus brevis. So this will never unite if you go for a conservative management. So conservative management and non-union can cause lateral sided pain, and this will mimic symptoms of peroneal tendinitis. But pain, tenderness posterior to the lateral malleolus will be absent. But if you ask the patient to evert, that will cause pain. So the other entity is the medial sided pain. Commonest one and the most important one is the tibialis posterior tendinitis. In addition to that, there will be tarsal tunnel syndrome, deltoid ligament sprain, accessory navicular bone or navicular bone AVN causing medial sided pain. But I am going to focus more on the tibialis posterior tendinitis, where there will be tenderness posterior to the medial malleolus extending into the heel. There will be significant tenderness with or without swelling. And the presentation is most of the time acquired flat foot. So in any adult presenting with an acquired flat foot, not a congenital one, not in the teenage, but an acquired flat foot, is tibialis posterior dysfunction until proven otherwise. So they will present with this flat foot, which is flexible. If you elicit the jack sign, if you extend the big toe, the arch will reappear. So this is a flexible flat foot in an adult is tibialis posterior dysfunction. And as you all know, tibialis posterior is an inverter of the foot. Peroneal are everters of the foot. Here tibialis posterior is having a dysfunction. So inversion is out and everters are overactive. So they will go into calcaneovalgus deformity. There will be calcaneovalgus deformity. In a normal person standing, we will be only seeing the little toe. But in these patients, you can see too many toes, which is known as the too many toes sign. And again, ask the patient to do repeated single heel raise test. That will be painful or there will be weakness, and resisted inversion will be difficult. But when you are assessing resisted inversion in tibialis posterior tendinitis, again, there is a confusion because tibialis anterior and tibialis posterior, both are inverters. So how are we going to differentiate? Tibialis anterior is an anterior compartment muscle, which is also the dorsiflexor of the foot. And tibialis posterior is a posterior compartment muscle, which will go plantar flexion. So if you ask the patient to dorsiflex and invert, that will be done by tibialis anterior. Here, this patient is keeping in dorsiflexion and inversion. You can see the tibialis anterior being active. But if you plantar flex and invert, that will be done by tibialis posterior. Here you can see the contracted tibialis posterior. So in contrast to here, this is tibialis anterior. While in plantar flexion, it will be tibialis posterior. So if you are looking for tibialis posterior, always assess inversion in plantar flexion. This will be difficult for the patient. So this is plantar flexion and inversion. So resisted inversion in plantar flexion will cause pain. That is tibialis posterior dysfunction. This is something that should not be missed, because if you miss a tibialis posterior tendinitis, that will progress to dysfunction, and then initially they will present with a flexible flat foot. If you miss it, they will move on to rigid flat foot, which is progression. Then they will need surgical management. Though rare, tarsal tunnel syndrome has to be kept in mind. They will have tenderness posterior to the medial malleolus. And the classical sign will be if you passive dorsiflex the foot. If you are dorsiflexing, you are stretching this nerve. So passive dorsiflexion will worsen the pain. Only thing is this can mimic plantar fasciitis because the distribution of pain is almost the same. So this can mimic plantar fasciitis, but paresthesia and tinel signs, which are not seen in plantar fasciitis, can be seen here. So if you are treating a patient with plantar fasciitis, not responding to management, always think twice, are we dealing with a tarsal tunnel syndrome? This is very, very rare because this is one of the strongest ligament in our body. So deltoid ligament sprain is very, very rare, and eversion injuries are also rare. So very uncommon, but they can present with medial sided tenderness just inferior to the medial malleolus with eversion instability. If you try to evert the foot, the eversion will be too much, but that is very rare. But I want to highlight on these two, accessory navicular bone and navicular bone AVN. Accessory navicular bone is a congenital abnormality, but they usually present at the age of 40 to 50. So these are usually middle-aged female presenting with medial sided pain. And if you examine the patient, they will have a flat foot, but the difference is this will be a rigid flat foot. When you extend the big toe, the medial arches will not reappear. So these are rigid flat foot, and there will be typical tenderness over here. And you can feel a bony prominence. Then you go for a weight bearing AP X-ray of the foot, and you will see these accessory navicular bones. If the pain is bothering the patient, this has to come out. So if you are dealing with a medial side pain with a rigid flat foot, think of accessory navicular bone, usually in middle-aged female. Whereas in hyperactive athletes or ballet dancers, this is another entity, navicular bone AVN or a stress fracture. So this is again a medial sided pain, but this point is defined as endpoint, that is navicular point. So classic tenderness, the maximum tenderness will be over this endpoint. So this is the landmarking of this will be just medial to the flexor hallucis longus tendon and just lateral to the tibialis anterior tendon. So if you place your thumb between the flexor hallucis and the tibialis anterior and press on it, there will be significant tenderness. So that could be a navicular AVN or stress fracture. Because navicular AVN, if it is well established, it will be seen like this. You can compare with the other side. It will be seen like this, which will not be missed. But in the early stages, this can be easily missed. And navicular stress fracture will be just a central radiolucent line, which if we don't clinically detect, it's very difficult to detect radiologically. And both has to be confirmed with MRI. So look for this endpoint tenderness. I have finished the major part. I'm just touching on anterior side pain. If you have an anterior pain, you are always thinking of ankle arthritis or subtalar arthritis. These will never present as isolated medial, posterior or lateral pain. There will be always anterior pain. So you think of ankle arthritis or subtalar arthritis, and the rare entities will be anterolateral impingement, osteochondritis dissecans of the talus, and tibialis anterior tendinitis. So ankle arthritis, there will be tenderness along the joint line with or without effusion and limited ankle range of motion. This is something again I wanted to stress on. if you are assessing the ankle range of motion, this is the way to assess the ankle range of motion. I'm sorry about showing photos because I didn't want to include videos which might not play during the presentation. So you keep your hand on the heel and the whole forearm should be in contact with the heel. Then you move your forearm. You can bend your body and increase the dorsiflexion and plantar flexion and make sure that the foot is in contact with your forearm throughout the range. Otherwise, these intertarsal movements may mimic ankle movement. So if you want to eliminate this, you make sure this is in complete contact. So there is no movement at the mid-tarsal or subtalar joint, and then elicit for the ankle range of motion. When you are looking for the subtalar joint movement, always lock the ankle, because ankle movement can mimic subtalar movement. So how are we going to lock the ankle? Go for the maximum dorsiflexion. Once you maximally dorsiflex, ankle is locked, and then look for the inversion and eversion. That will be the subtalar movement. So there will be tenderness at the sinus tarsi level with limited subtalar range of motion. These are rare entities, but if you have an anterior pain in a young patient who does not tell you with the diagnosis of ankle arthritis, think of osteochondritis dissecans of the talus. There will be effusion, there will be limited range of motion, there will be severe pain. Patient needs an MRI to detect for the osteochondritis dissecans of the talus. Tibialis anterior tendinitis, again seen in athletes. Tibialis anterior will be tender, so there will be tender point here. And if you try for a resisted inversion in dorsiflexion, which I have already explained, if you go for a resisted inversion in dorsiflexion, tibialis anterior pain will be aggravated. Finally, about forefoot pain, or known as the metatarsalgia. The common causes will be hallux rigidus, hallux valgus, transverse metatarsalgia, stress fracture of second, third, or fourth metatarsus, Morton's neuroma, and sesamoiditis. So hallux rigidus is again dealt with the rheumatologists more than the orthopedic surgeon. So there will be this dorsal bunion and limited range of motion of the hallux with osteoarthritic changes. So that is known as the hallux rigidus. Hallux valgus deformity itself will not cause pain, but then they have a painful bunion, there can be pain. And whenever you see a patient with a hallux valgus deformity, as you all know, you will be excluding any inflammatory arthropathies, but always ask for this weight-bearing foot AP, because a normal standard foot AP will not show the severity. We have to go for a weight-bearing AP. If it is severe, where we measure this intermetatarsal angle and the hallux valgus angle, if it is severe, and if it is painful, it needs surgical management. The spacers and the orthosis are not proven. It has to be surgically managed. Transverse metatarsalgia, you have these intermetatarsal ligaments stabilizing these metatarsal joints with and avoiding them being spread out. If there is any abnormalities, they can have this transverse metatarsalgia, that is pain along the metatarsal heads. And this will be a typical classical clinical sign indicating a possibility of transverse metatarsalgia, because our foot is meant to be a tripod weight bearing on heel, big toe ball, and the small toe ball. There should not be any significant weight bearing in these toes, but if a patient comes with callosities involving these metatarsal heads and forefoot pain, always think of transverse metatarsalgia. These are seen in patients like ballet dancers and athletes. Stress fracture of the second metatarsal, there will be tenderness over the metatarsals, and if you go for X-ray, you will see this excess callus formation or sclerosis. If you don't see this, the other differential diagnosis is a Freiberg disease. Again, in same population, active, young, there can be an idiopathic AVN of the second metatarsal head, which should not be missed, and the range of motion will cause pain, and there will be typical tenderness over the metatarsal. And if you do an X-ray, suspecting a stress fracture, and if you don't see a stress fracture, always think, oh, can this be AVN of the second metatarsal? Because this is an advanced stage. In the early stage, there will be only sclerosis. So these are the things I wanted to mainly highlight. Morton's neuroma, it's again a rare entity where they will complain of shooting pain. This commonly involves the third web space. So there will be shooting pain along these sides of the toes. And if you squeeze the metatarsals with your hand, there will be the similar pain will be the patient, that is known as the Mulder's sign. This is again a rare entity, sesamoiditis, again seen in athletes or runners. Sesamoid bones, which are the abductor hallucis brevis, can get inflamed and causes significant pain, and this pain will be aggravated by dorsiflexion of the big toe. There is pain and tenderness over the big toe ball. Always think of sesamoiditis, and there will be typical tenderness over the sesamoids. There are so many other causes like sinister causes like infection and malignancy. In any non-mechanical pain with a recent onset, we will always be thinking of infection and malignancy, but I have not included in my presentation because it will be there for each and every differential diagnosis. So I have excluded that. And when it comes to big toe pain and things, the gout and pseudo gout comes into play, but I didn't want to get into humiliation teaching gout to rheumatology, so I have avoided that intentionally. And there are rare causes like cuboid syndrome and sinus tarsi syndrome, which if we can't come to diagnosis, we can consider these as possible differential diagnosis. Take home message will be always, if the patient comes with the pain and tenderness, look for the site of this route map. The heel pain, medial, lateral, anterior, or the forefoot pain will help us to narrow down our differential diagnosis. So first, look for the site of and then do a focused examination. Elicit the specific signs and look for the focused examination. And in foot and ankle, radiology will only aid us in diagnosis because there are so many misleading facts in radiology. So if once you come to a diagnosis for confirmation, you can go for radiology. And our aim in assessing patients should be not to miss sinister causes. Possible, try and identify treatable causes so that patient will be relieved of pain. Thank you very much.
Very comprehensive and illustrative presentation. Are there any questions from the audience?
Thank you, ma'am.
Are there any questions? So in the absence of questions, I would like to thank Dr. Parthippan for doing this presentation for us on behalf of College of Specialty in Rheumatology and Rehabilitation. Thank you very much, Parthippan, for this nice presentation. Thank you.
Thank you, ma'am. Thank you, ma'am, for the opportunity.
Okay, thank you. Now our second speaker is Dr. Duminda Munidasa. No need of introduction. Dr. Duminda Munidasa, consultant rheumatologist in Rheumatology and Rehabilitation Hospital, Ragama, will be doing rehabilitation of limb amputees. Over to you, Duminda.
Thank you, Madam President, for introduction and this opportunity given for me to speak about a service done by our team at the Rheumatology and Rehabilitation Hospital, Ragama, as for the rehabilitation of limb amputees. Amputation is, by definition, is removal of a body extremity, which commonly occurs in the lower limbs with different levels depending on the condition of the patient decided by the surgeon. And there are much more detail of picture of different types of amputation that can happen in the lower limbs depicted here. Similarly, upper limbs also can have different types of amputations. The general causes are mainly the peripheral vascular disease, infections and gangrene, as well as malignancy. With the increased number of pandemic of diabetes and peripheral and the cardiovascular diseases now being in our community in such proportions, peripheral vascular disease, infections and gangrene are becoming major reason for the amputations which are referred to us. Of course, we still have the traumatic amputations, and rarely the congenital amputees are also shown to us. The way to recover from an amputation is by either transplant or prosthesis. The chances of transplant, especially in traumatic conditions, happen time to time, but its success is very rare. Hence, prosthesis is the main way the patients can recover their function. Just by application of a prosthesis generally will not allow the patient to resume their activities back in society. Generally, they need a very concentrated training program to make sure that they use the limb properly and they get the maximum functional outcome from that. And this need of training is what happened in the rehabilitation of an amputee. It is a difficult world for the amputee. There is so much psychosocial stigma, psychological breakdowns due to loss of the limb, the pain, phantom limb symptoms, learning to walk with the prosthesis and as well as crutches, which are much more energy, need much more energy. Applying and removal of the prosthesis need to be learned. They have to learn the care for the prosthesis for a longer usage, monitor the skin and personal spine pressure points, and ambulated on difficult terrain is a thing that they need to learn well. This rehabilitation process we can divide into 7 phases: the pre-operative phase, post-operative phase, pre-prosthetic phase, pre-preparatory prosthetic training phase, definitive prosthetic training phase, reintegration phase, and maintenance as needed. The pre-amputation assessment and counseling during the pre-amputation stage is as important part in the rehabilitation process, provided you have time for that, as sometimes, as you know, the amputation can be an emergency. But in planned amputations, even if there's day or two to go, it's better to have a rehabilitation team, as few members at least, involved and talking to the patient about what's happening and what is there for once he has an amputation. So referring them early, especially in the pre-amputation period, could be a benefit to the patient. It will give the rehabilitation team and chance to assess the success of prosthetic use, provide information on the possible outcome, reality check on patient's expectations, familiarizing with the concept of rehabilitation, cardiopulmonary conditioning program for the patient, and provide a chance to see the sample prosthesis and meet the amputees and rehab staff, so that patient knows what that there's, at least patient will come to understanding that there's some way, something that is there for him to get back to normal functioning, which will be psychologically very much helpful. Immediate post-operative phase is a shocking and depressing time period for these patients. Losing a limb, a part of a limb, is really a great loss that felt by all the human beings. Hence, need a lot of support during this time, not putting a corner bed and being ignored while in pain. So the pain control is one of the main goals in the immediate post-operative phase, which help the patient to psychologically feel better and accept the rehabilitation program. Stump management need to be started early, so that you have a good healthy stump, or at least prosthesis friendly stump for the patient to be able to use it functionally well. Promotion of wound healing, maintenance of range of motion with prevention of contractures, general endurance and strengthening exercises with strengthening of the upper limb musculature and balance training are helpful for the patient to learn, helpful for the patient to use the prosthesis well. The ideal stump should be well healed, well shaped, has a good vascular supply, soft and mobile scar at the end of the stump, having minimal pain and minimal edema, Length sufficient for a biomechanical leverage, but not too long to restrict the choices for prosthetic components. This should be well aware by the surgeon, otherwise that we run into problems of using a prosthesis available for us. Large surface area at the end of the stumps again is helpful to prevent pressure problems as well as pressure problems at the stump. Surgery plays a large part in creating an ideal stump, so it should be done technically correctly, hence that you don't get any issues when using a prosthesis. Then the physiotherapy is required to maximize the chance of achieving this ideal stump. Stump dressings are usually done to achieve many of these goals, mainly getting a good stump shape, improve healing, and prevent pain. We'll need a specially trained nurse physiotherapy to look after the stump, or at least patient, or most of the staff should be trained so that they can help the patient at any time. The dressing of the stump can be done by soft dressings, semi-rigid dressings, and rigid dressings. The rigid dressings or semi-rigid dressings seems to do better, but what is available for us in Sri Lanka is the soft dressings by using bandaging. Hence, knowing the bandaging techniques is very important. So I'm going to play a video where our physiotherapist, Mrs. Nuanigamage, is going to demonstrate how a bandaging should be.
To stump bandaging, we must know several facts. First, why we need bandage. Normally, the stumps are bulky with a lot of soft tissues and irregular in shape. So we have to correct the shape and as well as the size. For that, the size of shape of the stump must be a conical one or tapered one. So for those two facts, we use bandaging. The second one is the type of bandage we choose. Always the type of bandage must be a cotton crepe one with less elasticity like this. And it must be a strong and not fray easily, and also not a thick one. Then, as the bandaging is a compression therapy, there are several risks with wrong bandaging. When we exert wrong force to the stump, then we disturb our vascular system. So then in turn cause for the wound healing and blisters or ulcers, as well as it will mismatch the shape of the stump you must need for the prosthetic fittings. So by keep those in mind, let's move to the bandaging. You have to hold bandage like this. Hold the bandage like this and keep the bandage underneath your thigh just above the knee joint and pull the bandage downwards until you reach the stump end. Then there you can bring the bandage upward till you reach the same and opposite point where you start your bandage. There you have to wrap 2 rounds around the thigh. We wrap it to fix the bandage to the limb. Then there you cross the knee like this and bring the bandage to the distal limb. There you give a pull to downward and inward and bring it to the anterior side, and again you have to wrap once here. Then you bring the bandage to the same and opposite point, and here you start the figure of 8. By experience, you can understand what amount of force you need to do the correct bandaging for a particular patient. Here you have to be aware not to wrap your bandage one over another. Then it will create extra force to that particular point. Then likewise continue the figure of 8. And always keep in your mind not to make creases when you doing bandaging. It will also exert excessive pressure, as well as it will mismatch the shape of the stump. For this patient, we can use only one bandage, but there are some patients one bandage is not enough. Normally, we fix the last point, end point of the bandage most lateral to the stump, from avoid the other limb by damages from this.
That is figure of 8 bandaging for a below knee amputation, and this demonstrate what you do for a above knee, where the anchoring happens at the waist level. It's important to have your physiotherapists and nurses know about this, so this can be started soon after a surgery, maybe when the wound is little better, maybe within few days, and continue while we make preparations for a supply of prosthesis, so that the workload at RRH or where the prosthesis is being given will be less, and this can be done in any peripheral hospital. The stump shrinkers are also being used in other countries, where because the edema is a major reason, which can be done with the elastic ones or while casting, as well as using different devices that will cause the edema to reduce. Again, the bandaging itself will help in this endeavor to shrink the stump. One of the important things about the amputees, while wearing the prosthesis, they generally would like to keep in these natural positions when after amputation. The below knee amputation, will notice, is generally the knee will be in a flex position with the internal rotation, while the above knee, the patient will be flexing at the hip with the adduction. These are natural positions adapted after that because of the imbalance in the muscles, the stronger muscle causing this flexion in the knee, as well as the hip abductions in the above knee. These need to be prevented. If you leave like this, they will have this contracture, which will prevent them using a prosthesis. Hence, how to overcome that is by advising on good positioning, like sleeping on this way in a below knee, and also below knee when they are seated, giving what is called a stump board, which is prepared by the occupational therapist, which will minimize the knee flexion contractures. Early physiotherapy need to prevent the hip and knee flexion contractures, and which is again effective in the effective pain management. Also helps in preventing these contractures, because the pain, sometimes with pain, patient to go into a less painful position might take this, might keep the joints in a flexed or extended position. The above knee positioning should be as instructed here, to prevent the abduction, the flexion and the adduction position taken by the hip. In pre-position training, you train them, getting them into sitting balance, and remember the part of the body is gone, so the balance of the body loses with the weight being on one side. Hence, in training for the sitting balance, bed mobility, transferring in the correct way, maybe from the wheelchair to the bed at the beginning, and then later even from seated position, getting up and so forth. Upper limb strengthening is very important because most of the time they will need a walking aid, or even they need to be trained for crutch walking, as they may not be wearing the prosthesis always. Like if in the middle of the night they want to go to a toilet, there may not be enough time for them to put on the prosthesis and go. Hence, throughout the life they should have the skill of walking with crutches, and the self-care of the prosthesis need to be. All unilateral lower limb amputees should be taught to ambulate safely without a prosthesis by using bilateral crutches. This skill is needed, as I told before. There are maybe occasions when the artery will not be used. So, and when you do mobility without prosthesis, promotes residual limb maturation, acts as a short-term gait control, great training tool, and permit progression in physical fitness and exercise. There are different devices that can be used in this stage, which will help the ability to walk, prevent any contractures, reduce the volume and edema of the stump, as well as help in healing, like what is shown here, which is a pneumatic device which fix on and can walk on while waiting the prosthesis. The occupational therapists play a role here. They are the one who generally advise on what kind of wheelchair they need to use, and also make the stump boards, as well as different changes done for the wheelchair to prevent any falling, especially when you have bilateral amputation. Again, they need to assess their house, workplace for accessibility, as well as able to reach and get things for work or housework at home office. They train them to do things on crutches even without prosthesis, and then the prosthesis is provided by the prosthetist and orthotist. There are different components within the prosthesis, and these components need to be, brought ready-made, and then we make the outer coverings and the rest of it in the P&O clinic or workshop. They do it first by casting, and then get the negative cast, then do a rectification of that, and then they make the fabrication. After that, the fit and prosthetic will be begin. During the prosthesis training, we look at the gait and do correction adjustment. They have to educate the patient donning and doing, that is taking out prosthesis, how to put the sock put on stump, or put in the prosthesis. This is maintenance and monitoring, caring of the P&O physiotherapy. Will train the walking, use devices of prosthesis and more functional. To be trained for skin as these cause times, especially with diabetes. The initially every 10 to 15 minutes at the beginning using it, 1 or 2 monitoring foot, attention given to the dominance patient wear a coil action band prosthesis or at least aging as we do in this country. What is advisable is as it should be as soon as stump with standing apply and not nice wound. We'll wound here the first is done changing and be studied so that help trauma maybe within 6 or diabetes. Patient may be for about 1 month before starting the process of use. It's once the nursery told you have a as per within it's people improve because mean in the person the person and if sort of me for and transfer people the norm hence as phantom limb is a major problem faced by other body parts. Many will have pain, which is the most disturbing sensation, and some feel itching and twitches in this phantom limb. There are many treatments employed. One is with the occupational therapist. You can do the mirror box training, which by use of artificial visual feedback, it becomes possible patient to move the phantom limb and unclench it from the potential painful position. Medications can be given for this, gabapentin, pregabalin, amitriptyline use, and also physiotherapy techniques like tapping on the stump, which gives the body indication that there is nothing below that to the brain, which seems to be helpful in treatment of phantom. Once you are given and trained prosthesis, you need to reintegrate them in the society, at their home, at their workplace, where the occupational therapist should do a pre-assessment and should have changes recommended even before the patient gets the prosthesis. Follow-up is very important. Need to have amputee clinics. Social worker should get involved for the management of any social issues and financial help. Sometimes psychological review or supportive is helpful, and a surgeon and local doctor should be in charge in following up, especially looking after the stump even while using the prosthesis. The amputee rehabilitation services are not widespread in Sri Lanka yet. Of the Ministry of Health, probably only Rheumatology and Rehabilitation Hospital Ragama can offer a full because of well-made prosthesis. But this should expand as we will not be able to cope with all the amputees all over the country. At the moment, we are trying to serve Ragama and surrounding areas. Since now we are getting PNOs trained in the School of Prosthetic and Orthotics in Ragama and been posted to different major hospitals like NHSL, Karapitiya, probably Ampara as well as Anuradhapura, Kurunegala. I think those places should get the resources needed for them to make prosthesis and start making the prosthesis, which will be much needed in this country where the diabetes, as I told you, is causing a major issue, as well as still the trauma, especially road traffic accidents, are a major cause of amputation. There are a few non-governmental organizations still giving free prosthesis. There's Fred in Need giving Jaipur Foods, and there's Metta Foundation Maho, which with it's a UK-based foundation which gives you free prosthesis. There are a few private sector places also costing from maybe 2 lakhs to 4 lakhs for a prosthesis, depending on the type. One major issue with some of these private sector ones are the prosthetic training part is not there, which is not very good. I acknowledge my team's work on the service provided to our patients. So I would like to thank all the staff of Rheumatology and Rehabilitation Hospital, the SRs and medical officers, prosthetic and orthotic clinic, therapist, the physiotherapy department, occupational therapy department, social service officer in the hospital, nursing staff, and the minor staff who really contribute well to get a good service in prosthesis and orthosis in our hospital. As of this presentation, I would like to acknowledge and thank Dr. Gunendra Kasturatna, Mrs. Nuani Kamage, our physiotherapist, and Mrs. Shamila Sandralingam, our PNO, for allowing me to use some of their slides in this presentation, and Sri Lanka School of Prosthetic and Orthotics for use of the video made by them on bandaging by Nuani. Thank you very much for the patience listening, and thanks again college for allowing me to do this presentation. And if there is time and if you have questions, I'm happy to answer them. Thank you very much.
This is time to ask you questions. Do you have any questions? If you have questions, please ask. Unmute and ask questions.
Yeah, sorry about the disturbance in middle of the presentation. I think what you missed is mainly on the using a prosthesis. All patients will need higher amount of energy spending. Even Sims at ankle, half foot level, the amount of energy needed is about 20% more than the 20% more than the normal person's walking. Hence, that all has to concentrate very well on the upper limb strengthening as well as cardiovascular conditioning in the pre-prosthetic stage. So that is, I think, something which we missed, which we need to stress, because most of the pre-prosthetic can be done in any of the hospitals where we have the physiotherapy departments, and it doesn't need to be in our hospital.
Thank you, Duminda, for this excellent presentation. On behalf of the college, I would like to thank. Then we will move to the next speaker, Dr. Uthpala Dissanayake, consultant in Rheumatology and Rehabilitation, Teaching Hospital, Kegalle, to present overview of thrombotic microangiopathy. Over to you, Uthpala.
Madam, I hope everyone can see the screen.
Yes, it's clear. Yeah.
Yeah. Good afternoon, everyone. Thank you for giving me this opportunity to talk to you on overview of thrombotic microangiopathy. Actually, this is not a commonly discussed topic in rheumatology meetings, but I'm sure many of us were asked by our colleagues to see patients with thrombotic microangiopathies in our day-to-day practice. Therefore, I thought it is better to know something about thrombotic microangiopathy. I will be talking to you on these topics today: introduction, definition, classification, how do you approach a patient with suspected thrombotic microangiopathy, an evaluation of a patient with primary thrombotic microangiopathy, few words about TTP, and then of course take home messages. As I said,
Excuse me, Uthpala, can you make it full screen?
Isn't right? Can't you see?
Yes.
You can see it, but you'd have to switch off the presenter view.
All right. Okay. Sorry. Right?
Yeah.
Okay. Now.
All right. Okay. Okay. Sorry about it. So as I said before, so here I have summarized why we should know about thrombotic microangiopathy. Thrombotic microangiopathies are actually systemic diseases which can simulate many of the vasculitic conditions and connective tissue diseases. Therefore, most of the time, our colleagues ask for our help. Therefore, we must know about it. And thrombotic microangiopathies are diseases with very high mortality. Some of the diseases actually have 90% of mortality left untreated. And with treatment, we can reduce the mortality significantly. Therefore, we have to act promptly. So we might not have enough time to go and refer and come back and initiate the treatment. So we have to have some idea about these diseases back of our mind so that we can implement or start the treatment as quickly as possible. And thrombotic microangiopathies can affect any person from neonate to elderly, not sparing pregnant mothers. So therefore, all of us should know something about thrombotic microangiopathies, including obstetricians. And they are very rare diseases, not very common. If we know these diseases only, we can have high degree of suspicion and take them at least into a list of differential diagnosis. What is thrombotic microangiopathy? Thrombotic microangiopathy itself shows us what is it actually. There is thrombosis and microangiopathy. Microangiopathy means there is a defect in the microvasculature, including arterioles and capillaries. Usually the defect is in the endothelium. This can be caused by many mechanisms depending on the underlying etiology of the thrombotic microangiopathy. Because of these endothelial damages, there will be thrombosis happening in the microvasculature. And it will be clinically evident as thrombocytopenia and microangiopathic hemolytic anemia. Thrombocytopenia, of course, happens secondary to the consumption in thrombosis. Therefore, the thrombocyte level will be low, not because of the destruction, but as they are consumed in the thrombosis. And when there is microangiopathy, because of the defects in the small vessels, the intravascular hemolysis will happen inside the microvasculature, and it will become clinically evident as microangiopathic hemolytic anemia. So finally, when there is thrombotic microangiopathy, clinically this patient will come to us with thrombocytopenia and microangiopathic hemolytic anemia. Those are the two main features of thrombotic microangiopathy. Few words about MAHA or microangiopathic hemolytic anemia. It is non-immune hemolysis. Therefore, direct agglutinin test is negative, Coons negative, though there is hemolysis. And the hemolysis happen in the intravascular compartment, and there will be red cell fragmentation inside the blood vessels, small vessels. Therefore, you will see schizocytes in peripheral smear. And because of this intravascular hemolysis, LDH level will be high, indirect bilirubin will be high, and of course haptoglobin will be low because of the release of hemoglobin into blood. So this is the proper definition. Thrombotic microangiopathy describes a specific pathologic lesion actually, in which abnormalities in the vessel wall of arterioles and capillaries lead to microvascular thrombosis. TMA is a pathologic diagnosis made by tissue biopsy, typically a kidney biopsy. However, it is commonly inferred from the observation of microangiopathic hemolytic anemia and thrombocytopenia in the appropriate clinical setting. Not all microangiopathic hemolytic anemia is caused by thrombotic microangiopathy, but nearly all thrombotic microangiopathies cause microangiopathic hemolytic anemia and thrombocytopenia. This classification, actually, this is a bit tricky. You have primary thrombotic microangiopathy syndromes, but when the similar patients are associated with other diseases, they are not called secondary TMA syndromes, but that category is called systemic conditions with microangiopathic hemolytic anemia and thrombocytopenia. And when there are no underlying systemic conditions with thrombosis and microangiopathy, we call it primary thrombotic microangiopathy syndromes. I think it is clear to you. So in primary thrombotic microangiopathy syndromes, there will be no other systemic disorders. This classification is made in this way because of the management concerns. Primary thrombotic microangiopathy syndromes are managed differently, whereas systemic conditions with similar pictures are managed differently. In this patients, actually, all you have to do is to manage underlying disease, then eventually the microangiopathy and thrombosis will be treated. Right, so you have two main categories: primary thrombotic microangiopathy syndromes and systemic conditions with microangiopathy, hemolytic anemia, and thrombocytopenia. So when you have a patient, all we have to do is to differentiate these two categories. Right. So we'll talk about primary thrombotic microangiopathy syndromes. These are the types. I think we are well aware of thrombotic thrombocytopenic purpura, very popular topic among our MD Part 2 exams. TTP can be hereditary and acquired. And I will just discuss few things later. And then Shiga toxin-induced hemolytic uremic syndrome is a primary thrombotic microangiopathy. And there are drug-induced thrombotic microangiopathies. Drug-induced ones can be immune-mediated and directly dose-dependent non-immune microangiopathies. Here, the microangiopathy occurs secondary to antibody response. Here, the drug itself directly will damage the endothelium and cause microangiopathy and thrombosis. And there is another variety, complement-mediated thrombotic microangiopathy. It is also, these three are the common ones. Actually, these three are less common. These two are, of course, very, very uncommon. You can see complement-mediated thrombotic microangiopathies also in clinical practice, though rare. Now, those are the types of primary thrombotic microangiopathies. Then the other category is systemic conditions with MAHA and thrombocytopenia. We all know these things. Pregnancy complications like preeclampsia, pregnancy-induced hypertension causing preeclampsia, and HELP syndrome. And systemic infections like HIV, bacterial endocarditis, cytomegalovirus, malaria, all these diseases, all these infections can cause microangiopathy and thrombosis. And severe hypertension, of course, can cause microangiopathy and thrombosis, systemic malignancies, systemic rheumatic diseases, mainly SLE, systemic sclerosis, and antiphospholipid syndromes can cause microangiopathy and thrombosis due to endothelial damages and non-immune thrombosis. And DIC and severe vitamin B12 deficiencies are the systemic conditions which can present as primary thrombotic microangiopathies. Right. Then we'll move on to the management. How do you approach a patient with suspected thrombotic microangiopathy? I know it might not be easy actually, because these patients are ill usually. So therefore, it might be difficult to identify underlying systemic conditions like SLE at the beginning or at the outset. The initial evaluation of a patient must focus on distinguishing primary symptoms from other systemic disorders. Most of the time they say the patient can initially present with, first presentation could be thrombotic microangiopathy-like picture, but when you try to exclude the systemic conditions only, you are able to recognize the underlying malignancy. Therefore, in first day or two, you might consider, because it takes little time for you to diagnose the underlying malignancy, but you should start the investigations anyway, but until that you can manage those patients as primary thrombotic microangiopathies, but always you must try to exclude the other systemic disorders. Once systemic disorders have been excluded, the focus actually changes. Then you must identify which type of primary TMA is that, because different TMAs have different management. Certain primary TMAs need initiation of treatment within hours to prevent death. These two are the main two TMAs that you have to identify promptly. Thrombotic thrombocytopenic purpura, because you have to start a plasma exchange within hours, otherwise patient can die. And the other category is complement mediated thrombotic microangiopathy. This is anti-complement medication. This is not available in Sri Lanka, but this medication can completely hold the disease and prevent patient from dying. Right, then how will they present you? Of course, I said there will be thrombocytopenia. At the beginning, you will identify the unexplained thrombocytopenia, unexplained anemia, and unexplained neurological findings. Why I say unexplained is sometimes this patient could be a young man who is in 20s or 30s, who has no other diseases to cause thrombocytopenia. No, the patient had been very healthy until 2-3 days ago. So your anemia is not explainable, and patient might have features of TIA, sometimes diplopia, aphasia. They will have unexplained neurological findings because they are not they are not in an age where they would get stroke. And patient will have other acute symptoms, abdominal pains, features of pancreatitis, diarrhea, those type of symptoms. So you can clearly see that These are the patients we usually see. Connective tissue diseases, SLE, antiphospholipid syndrome, all these patients will present in this way. But it is really important in this patient to exclude other systemic diseases and identify primary TMAs to save the patients. Right. All you have to do is thorough history and examination. More you use time for this, the number of tests you have to order will be reduced. So at the end of the examination and history and examination, you have to order blood tests. Since this is overview, I'm not going to discuss about all the investigations, but your aim would be to confirm the presence of microangiopathic hemolytic and thrombocytopenia and exclude other systemic diseases. So, since the cornerstone of the diagnosis is microangiopathic hemolytic anemia, it should be verified. It is usually done by, it is just the review of peripheral blood smear by a hematologist. That's how you confirm the microangiopathic hemolytic anemia. Automated cell counters can often detect schizocytes, especially when they represent more than 1% of RBCs. Just to remind you of the schizocytes, these are helmet cells, these are fragmented cells, these are spherocytes. This is the typical peripheral smear in microangiopathic hemolytic anemia. So if you cannot, when patient presents with this, if microangiopathic hemolytic anemia is not present, other acute systemic illnesses associated with pancytopenia must be considered. Of course, thrombotic microangiopathy can occur in SLE and other scleroderma and antiphospholipid syndrome. But if at the initial presentation, if these features are not, microangiopathic hemolytic anemia is not there, then we can think of other diseases like this connective tissue diseases, SLE and antiphospholipid syndrome, and we can manage the patient in that way. Right. So if microangiopathic hemolytic anemia is there, and if there are no significant systemic symptoms, mechanical causes should be excluded, like intravascular devices, hemangiomas, and physical, thermal, and osmotic injuries. Once the mechanical, but with microangiopathic hemolytic anemia, if systemic symptoms are there, again, the same thing, you have to exclude the other diseases which can activate intravascular clotting, and then you have to look for thrombotic microangiopathy. And if microangiopathy hemolytic anemia is absent, then you have to think of other acute systemic illnesses with pancytopenia. This is the genesis of schizocytes. Actually, this is a fibrin gland. This is the endothelium. This is how the red cell is fragmented by the fibrin strand. Right. This is how you approach, a summary of approach. I'm sorry, I don't know if you can read. So you have a patient in whom you suspect thrombotic microangiopathy, and the thrombocytopenia and MAHA is confirmed. And you look for underlying conditions which are common in adults, uncommon in children. So if patient is an adult, it's common to have underlying disease. So you just check whether there is DIC. There will be significant differences in clotting parameters and amount of the percentage of thrombocytopenia. Reduction of thrombocytopenia will be significantly reduced, change in these two conditions actually. And you look for underlying malignancies, preeclampsia, severe hypertension. You have to exclude these diseases. If you diagnose these underlying conditions, then you have to focus on underlying conditions. The management of these conditions will eventually help thrombotic microangiopathy. If you cannot identify underlying condition, then if the patient is an adult, look if there is kidney injury or not. Sorry. If there is minimal kidney damage, if creatinine is normal, if there is no hematuria, if there is no kidney injury or minimal kidney injury, then the diagnosis, presumptive diagnosis would be thrombocytopenia. So you have a patient who has microangiopathic and thrombocytopenia, MRI and thrombocytopenia, and you cannot find the underlying condition. And then patient is an adult and has no kidney injury. Patient must be ill, maybe having mild fever, abdominal pain, pancreatitis, the patient is ill, but without significant kidney involvement. Then you think of TTP and you don't delay the treatment, and you must start treatment immediately. And then if there is kidney injury, if it is acute, the first thing you have to exclude is drug-induced immune thrombotic microangiopathy. I will give you the medication list later. So drug-induced immune-mediated thrombotic microangiopathy will cause significant acute kidney injury. So you have to look for the drug treatment and then stop the offending medication. And then, of course, adults can have Shiga toxin HUS if there is kidney injury. And if it is acute, you have to ask if there is diarrhea. And you can diagnose this by the history. Complement-mediated TMA, of course, by the exclusion of other things. These metabolism-mediated and coagulation-mediated ones are very rare. I don't think they are usually seen in children, but adults also very, very rare. And TTP less likely to cause acute kidney injury, but still you can consider it as well. And if the kidney injury is chronic, if it has happened over weeks and months, then you have to think of non-immune drug-induced thrombotic microangiopathy. Usually the chronic renal impairment happens over months in this variety. And if the patient is a child, just see if there is diarrhea with blood. If there is diarrhea with blood, the diagnosis would be HUS and you have to manage accordingly. And then if there is no bloody diarrhea, diarrhea with blood, then you have to think of these diagnoses. Hereditary TTP, complement-mediated metabolism coagulation-mediated TMA is of course very rare. Complement-mediated TMA you have to think of. And drug-induced ones are always also uncommon in children. Hereditary TTP, acquired TTP again uncommon in children. Hereditary TTP and complement-mediated TTP you can you have to think of. Actually, there is a way that clinical way to diagnose thrombocytopenia, which I will discuss later. Thrombocytopenic purpura, which I will discuss in following slides. Sorry about this congested slide, but there is no other way of putting this. These primary TMA syndromes, this is the syndrome. Here I will just mention some clinical features and the laboratory findings. TTP, they can have very severe neurological abnormalities. That is the most important thing. Inherited one may present in a newborn infant. A child with thrombocytopenia, in a child with thrombocytopenia, you have to suspect inherited TTP if that child has neurological abnormalities. Inherited one is less common in adult. Usually, if inherited one is going to present in an adult, it happens usually during the first pregnancy. Sorry. And acquired autoimmune TTP is uncommon in children. Again, the microangiopathic hemolytic anemia and thrombocytopenia will be very severe in TTP compared to other ones. Acute kidney injury is rare. This Adams 13 activity will be less. Acquired cases will have a detectable Adams 13 inhibitor, which of course we cannot assess. None of these things can be done in Sri Lanka. In India, private labs I just inquired private labs, if you really want, private labs sometimes do this for us from India. And then the next one is complement-mediated thrombotic microangiopathy. Again, it can be inherited or acquired. It can present in children or adults. In this type, renal failure is prominent. Most of the time in our setting, actually, we have to do we have to diagnose certain diseases by exclusion. So you can see HUS, of course, you can diagnose when there is associated diarrhea. It is a type TMA which can have renal failure. Of the others, actually, drug-induced ones, we can, most of the time, we will be able to identify offending drug. If those things are not, if we can safely exclude these two, complement-mediated TMA is the possible diagnosis. Actually, renal failure is very prominent in this type. And it can be acquired, and there will be antibodies to complement factor H and I in these patients, which we cannot detect in Sri Lanka. And then Shiga toxin mediated hemolytic uremic syndrome, of course, abdominal pain, diarrhea with blood most of the time, possible history of outbreak or exposure to livestock or contaminated food, although most cases are sporadic. Renal failure is prominent. Stool may be positive for the organism, and Shiga toxin. Then drug-induced thrombotic microangiopathy. Drug-induced one can be immune-mediated and direct toxic. There will be history of exposure to quinine. Quinine is very important drug which can cause thrombotic microangiopathy or other implicated medication. Immune-mediated forms have an abrupt onset with fever and chills, abdominal pain, nausea, anuric kidney injury. So drug-induced immune ones are have very explosive, rapid onset. Toxic dose-related thrombotic microangiopathies are very slow to start. Yeah, again, laboratory findings, immune-mediated ones will have severe acute kidney injury. Drug-dependent antibodies to platelets and neutrophils can be demonstrated. Toxic dose-related one may have gradual or sudden onset of renal failure and hypertension. Though they say sudden onset, most of the time it's very gradual onset. These coagulation-mediated and metabolism-mediated ones are very rare. Then the next one, systemic disorders that may present with microangiopathic hemolytic anemia and thrombocytopenia. So syndrome is DIC, may be caused by infection, malignancy, PPH, hypertension, or hemangiomas. So laboratory findings would be thrombocytopenia. In these patients, actually, the thrombocytopenia will not be as low as in TTP. And there will be decreased fibrinogen, which will not be seen in the TTP because the thrombus are mainly formed by platelets. Usually the clotting cascade is not much involved. And elevated D-dimers are seen in DIC, but usually it's not seen in TTP. In TTP, those will be mildly elevated. And elevated D-dimers are typical with acute or chronic DIC. MAHA may occur. Prolongation of the PT and APTT are seen in acute DIC. Systemic infections. These are the infections actually. Gram positives, bacteria, Rickettsia, Borrelia. With dengue, you can get microangiopathic hemolytic anemia and thrombosis and leptospira, the common infections in our country. So these are the infections which can be associated with microangiopathic hemolytic anemia and thrombocytopenia. Therefore, always when these patients are there, when patient is presented to you, we don't have to jump immediately diagnose TTP, but look for possibilities of these infections. Right. And then pregnancy-related syndromes, of course, we know the patient will be pregnant. Typically, severe preeclampsia and HELP syndromes will present in third trimester or postpartum. Severe hypertension and liver involvement are often present. And the typical feature is abnormality usually resolve with delivery. If they are persistent, then you have to consider primary thrombotic microangiopathies. Elevated hepatic transaminases will be there. Acute kidney injury is usually unfound. Severe hypertension. So that, of course, again, you can diagnose pressure will be high. And hypertension, this is actually including press means there is encephalopathy syndrome, which again patient will have posterior encephalopathy, mainly the cerebellar symptoms. Hypertension may also occur in primary TMAs with severe renal involvement. So the temporal relationship is important. Abnormalities resolve with control of the blood pressure. Often associated with severe renal failure, renal barks demonstrates TMA identical to the primary TMA syndromes. Therefore, it is very important to get the history and see the improvement of clinical symptoms and signs with the control of blood pressure, which will not be seen in primary thrombotic microangiopathies. Then systemic rheumatic diseases. Again here, SLE may be associated with hypertension, renal insufficiency, and autoimmune cytopenias. APS typically present with arterial and venous thromboembolism, but can also produce thrombotic microangiopathy. Serologic testing may show autoantibodies. Yeah, so from the serologic testing, we can identify the underlying autoimmune systemic rheumatic disease. And here again, renal biopsy may demonstrate TMA identical to the primary TMA syndromes. Here, of course, it is very tricky because we know in acquired, if we go back to the previous slide, in TTP, you have acquired autoimmune ones, inherited ones, and acquired autoimmune ones. In acquired autoimmune TTP, they say most of these patients have underlying SLE. But when you read about the management, they always say if this is the first presentation of thrombotic microangiopathy, if patient has no SLE previously diagnosed, but later sometimes you might get the diagnosis of SLE later, but until that time you must treat that patient as TTP and start plasma exchange. You should not wait even if you suspect underlying SLE in that patient. Why I said it was tricky is because in some areas they say treatment of SLE will cure the microangiopathic hemolytic anemia and thrombocytopenia. In certain references, actually they say all you have to do is management of SLE that will eventually cure the thrombotic microangiopathy. But same time they say that if the acquired TTP is usually common among SLE patients, in that instance TTP should be treated. So you have to, anyway, what I gathered from reading is always if you suspect TTP, you have to start plasma exchange. If it is not going to respond, then anyway, TTP will be treated with steroids and rituximab. So you can start them later and that will eventually treat SLE as well. And a hematopoietic cell transplant and solid organ transplant, they can present with microangiopathic hemolytic anemia and thrombocytopenia. So now we'll move on to, first what we do is if we have a suspected patient, we exclude the systemic diseases. Now we know this patient has primary TMA, then you have to identify the type, evaluation of primary TMA. The key decision point in the evaluation for primary TMA syndromes is the confidence of the treating clinician that TTP is the correct and ultimate diagnosis. So you always try to look at the patient and see if this is TTP, because it is treatable and death is preventable. The rationale for focusing on this distinction is that TTP requires urgent intervention with plasma exchange within hours rather than days to prevent serious or potentially life-threatening complications. So we have to, if it is a primary TMA, we should see whether it is TTP. And the next one you should identify is complement-mediated TMA. Patients with complement-mediated TMA, such as patients with postpartum acute kidney injury, may also require urgent anti-complement treatment to prevent irreversible kidney damage. Usually, other primary TMAs are generally treated with supportive care, at least for the initial day or two. So, you know, in our setup, we cannot check the Adams 13 level or the activity. So there are ways to assess the probability of TTP. Probability of TTP can be calculated by the plasmic score. If actually Adams 13, even if Adams 13 activity is available, it takes time for them to get results, sometimes 1 to 2 days. So until that time, you cannot wait. So you can assess the probability by this plasmic score. This is the plasmic score for estimating the likelihood of severe Adams 13 deficiency in adults with suspected TTP. So you give one score for each: platelet count less than 30,000, one or more indicators of hemolysis, creatinine count more than 2.5, haptoglobin undetectable, indirect bilirubin, no active cancer in the preceding year. So you cannot wait for the investigations of this presentation. No active cancer in the preceding year, no history of solid organ or hematopoietic stem cell transplant, MCV more than 90 femtoliters, INR less than 1.5, creatinine less than 2. So INR can be abnormal, but that abnormality is low. And creatinine can be abnormal, but that is not very severe injury. So if plasmic score is 0 to 4 low risk, 5 intermediate risk, 6 to 7 high risk. In intermediate and high risk, you have to initiate treatment promptly. So then that is how we assess the probability of TTP. Now we'll see how we assess the probability of complement-mediated TMA. It requires actually the exclusion of other causes of microangiopathic hemolytic anemia and thrombocytopenia associated with increasing severe acute kidney injury, as I said before. So HUS should be excluded, and drug-induced TMAs should be, drug-induced immune-mediated TMAs should be excluded. Then you are left with this one, and we don't have this medication. It is a monoclonal antibody designed to selectively block terminal complement activation. Eculizumab may prevent end-stage kidney disease and reverse acute kidney injury. Therefore, its empiric use is appropriate in patients with rapidly advanced kidney failure. So you don't have to actually confirm the diagnosis. You just see if you can exclude the other two, and you start eculizumab if it is available. Just few words about the presentation. So primary TMAs, so it can be a child or an adult, and the onset of disease can be very sudden onset with severe illness, or it can be gradual onset with minimal symptoms as well. So they can present in either way. And the kidney injury can be anuric, an acute kidney injury, or normal kidney function. So they have variety of presentations. So we have to keep these presentations in our mind. There are some key distinguishing features among the primary TMA syndromes. They are patient's age, the time course over which symptoms developed, and the severity of kidney injury. Actually, I have already discussed these things. Age, if the child is neonate or infant, if patient is referred to you with first days of life, think of hereditary TTP. Sorry. think of hereditary TTP. And in infants, these ones can be there, but it is very rare. In young children, STHUS is a possibility, and any other primary thrombotic microangiopathies are possible, but this is the most possible thing, so you can exclude it. And in adults, acquired TTP, drug-induced thrombotic microangiopathy, and hereditary complement-mediated TMAs are the common ones. So in adults, you don't think of these rare ones. And then onset, explosive onset. As I said before, it is immune-mediated drug-induced thrombotic microangiopathy. It starts within hours of drug exposure. So you can see it in patients' drug history. And most primary TMAs are of gradual onset. And this is drug-induced toxic dose-dependent one is very slow onset. Again, I'm sorry about this. So the drug reported to cause drug-induced thrombocytopenic thrombotic microangiopathy. Here you have the immune ones. Here you have the non-immune ones. Quinine can cause immune thrombotic microangiopathy, as I said before, explosive onset with anuric acute kidney injury. The other, the common ones, cytotoxics and immunosuppressants are there. Antibiotics, sulfamethoxazole can cause immune thrombocytopenia. And sorry, I can't enlarge this as well. Valproic acid can cause non-immune, slow onset chronic kidney injury, secondary to thrombotic microangiopathy. And illicit drugs, of course, can cause a non-immune thrombotic microangiopathies. And according to kidney injury, again, you can suspect the type of primary thrombotic microangiopathy, minimal or no kidney injury, hereditary or acquired TTP, sudden severe immune-mediated drug-induced thrombotic microangiopathy, commonly and very rarely this, onset over days, HUS and complement-mediated ones, and onset over weeks, drug-induced dose-dependent thrombotic microangiopathy, usually immunosuppressives and chemotherapy, chemo agents. So a few words about TTP, as it is the thing that we finally have to identify. It is defined by severe deficiency of Adams 13. It is unique among the primary TMA syndromes for minimal abnormalities of kidney function, despite microthrombi observed throughout the kidney at autopsy. So you diagnose it actually renal biopsy, but you will not have abnormality, you will not see significant abnormality in the kidney functions. TTP typically has more severe thrombocytopenia and more systemic manifestations of organ injury than other primary TMA syndromes. Abnormalities of the central nervous system, heart, pancreas, thyroid, adrenal glands, intestinal mucosa, and other tissues may occur. So not only central nervous system, though we talk about it always, all the other systems except for kidney and lungs can be involved severely. There are no specific clinical features that distinguish TTP. Most patients present with several days of non-specific symptoms such as progressive weakness, fatigue, purpura, and gastrointestinal symptoms. Approximately 1/3 patients have no neurological symptoms. 1/3 may have non-specific symptoms like confusion and headache. 1/3 will have more severe neurologic symptoms such as transient focal neurologic abnormalities, aphasia, diplopia. And in many cases, the focal symptoms occur transiently. Yeah, if it is generalized only, they will last longer. Focal symptoms usually transient. Patients with TTP often have minor purpura related to severe thrombocytopenia and rarely have overt bleeding. Fever is uncommon, though as I can remember, when we study, we always remember TTP as fever, neurological involvement, thrombocytopenia, and MAHA. But now they say fever is uncommon in TTP. Those days, actually, they were not able to identify other primary syndromes. It's only now they are identifying the other primary thrombotic microangiopathy syndromes. But high fever with shaking chills rarely occurs. So that's all about thrombotic microangiopathy actually. Diagnosis cannot be delayed. Primary TMA should be identified promptly. Systemic diseases with thrombosis and MAHA should be managed according to the underlying disease. And do not delay the treatment of TTP even if you suspect underlying systemic disease if a patient has severe probability for TTP. Thank you.
So at the end of the presentation, do you have any questions? So what is the treatment of antiphospholipid syndrome associated thrombotic microangiopathy, Uthpala?
Madam, they always say there is no specific treatment for thrombotic microangiopathies associated with autoimmune diseases. That's what they say. But again, if that patient is present to you for the first time and later you might think you might have some features to suggest underlying APLS, still management would be the same, madam. Even if you have no proper confirmed diagnosis of APLS, then still you will go for the plasma exchange and then steroids and rituximab, madam. That's what they say. If you suspect TTP, I mean, if there's no clear evidence for underlying disease, manage it with plasma exchange.
Drug induced?
And they say, madam, and they say, if you don't see improvement within first 2 to 3 days, then think of other systemic conditions. That's what they say, madam.
Drug induced one, is there any treatment? Drug induced?
No, madam, it's just the removal of offending drug. The drug induced ones, madam, it is the immune mediated, that quinine is the mostly implicated medication, madam. It's very anuric. They just give the supportive care, and then I mean, if patient is anuric, you hemodialyze, and likewise supportive care, you stop the offending drug.
So in the absence of further questions, so I would like to thank Dr. Uthpala Dissanayake for this excellent presentation on behalf of the College of Specialists in Rheumatology and Rehabilitation. I would like to thank all three speakers for their excellent presentations, Dr. Balasundaram Parthippan and Dr. Duminda Munidasa and Dr. Uthpala Dissanayake. Thank you all for participation. So we will meet again on 4th of June in next meeting. Thank you.
Thank you.